Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
Hello, everyone. My name is Catherine. I'm the intern at Blum Patient and Family Learning Center.
Today's program is our Blum Center Cancer Center series, a special collaboration between the Blum Center and Mass General Cancer Center. Before I get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it will be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so we can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Catherine, who will introduce you all today's guest speakers.
Thank you, Amy. Today we have the immunotherapy team at the Mass General Cancer Center here to give a talk on immune checkpoint inhibitors, what patients should know about living with immunotherapy. Please join us in welcoming them.
Hi, everyone. My name is Ross Merkin. I'm a medical oncologist. I treat head and neck cancers and non-melanoma skin cancers, and I'm a member of the Immunotherapy Complications Service at Mass General.
Hi, everyone. I'm Alex Sorrentino. I am one of the nurse practitioners in the Cancer Center with the melanoma and non-melanoma skin cancer group.
Hi, everyone. My name is Leire Zubiri. I'm an oncologist doing a kidney fellowship now focused on immune-related nephritis and also part of the severe immunotherapy complications service.
Hi, everyone. My name is Shireen Rohani. I am an oncologist that primarily works with inpatients who have been hospitalized as part of their cancer journey.
I'm Riley Fadden. I'm a nurse practitioner in the melanoma and non-melanoma skin cancer clinic. And I also am the director and run our survivorship program for melanoma and non-melanoma patients with a heavy focus on immunotherapy.
So I'll get us started. So the title of our talk is Immune Checkpoint Inhibitors: What Patients Should Know About Living with Immunotherapy. So today we've broken up our talk into four components. The first, we'll talk a little bit about the background of immunotherapy and immune-related adverse events. We'll then spend a little bit of time reviewing some cases that we've seen during our clinical experience to kind of make some of the things that we talk about seem a little bit more grounded. We'll then go on to discuss restarting immunotherapy after an immune-related adverse event. And we'll finish with a discussion about survivorship during and after immunotherapy. So why is immunotherapy used to treat cancer? So first, on the left-hand side here, you can see that we've highlighted that immunotherapy and chemotherapy are very different kinds of cancer medicines. There are many kinds of cancer medicines. Chemotherapy is quite old. Its origins actually go back to World War I, when people exposed to mustard gas, went on to develop blood cancers, and then it turned out that mustard gas derivatives could be used to treat cancer. But it works in a very different way than immunotherapy. So chemotherapy targets very rapidly dividing cells, and those kinds of cells are heavily concentrated in our GI tract and in our bone marrow. Immunotherapy has a very different mechanism of action. It activates the immune system to attack the cancer that's in your body. And so that leads to very different side effect profiles and can potentially lead to very different kinds of cancer outcomes. So on this graph on the right here, you can see this is a graph that we call a Kaplan-Meier curve. In many scientific papers that describe how effective a cancer medicine is, we'll see a Kaplan-Meier curve, and what you're essentially showing, the person with the cursor can point out the y-axis, that the percentage here on the top, the y-axis, so be able to. There we go. Yeah, so the y-axis there. So basically, as this goes from 100 down to 0, it's showing the percentage of patients that still have not had any cancer grow. And then the x-axis is showing time. So, as we move farther along in time. And essentially what you see is after a certain period of time, each of these 3 separate lines starts to look kind of flat. And when we see flat lines on something called the Kaplan-Meier curve, especially for progression-free survival, that's what PFS is here on the y-axis. What that we essentially translate that to is that this person has probably achieved a very long-term control of their disease because the immunotherapy is either killed it all or is keeping it at bay. And that kind of effect is something we don't see with a lot of other kinds of cancer medicines. Next slide. And I just briefly wanted to show you, this is a patient of mine. I have permission to, from this patient to show you. This is a few months before treatment. This is a few days before treatment with immunotherapy. She had a skin cancer of her ear that had come back after surgery, and you can see all those little round circles are tumor growths, and those are quite large actually. We're talking about things. That thing that's being pointed to right now is probably over an inch in size. And 4 months of immunotherapy left her with no evidence of any cancer. And so there are times where we can really see people experience a lot of clinical benefit from immunotherapy. Next slide. But everything we do in the treatment of cancer has some trade-offs. When it comes to immunotherapy, those trade-offs come in the form of side effects or immune-related adverse events. And so this figure here on the right-hand side is basically just showing arrows to all the different parts of the body that can be commonly affected or uncommonly affected as well. And so when we see side effects from immunotherapy, when we give immunotherapy, what we see are that, on the left-hand side here of this flow chart, we're highlighting that the immune system is reinvigorated to attack the cancer, but on the right-hand side of the flow chart also potentially can attack normal healthy tissues. And so on the left-hand side, that leads to destruction of cancer, and on the right-hand side, it leads to destruction of normal healthy tissues. And so the benefits of the left-hand side of this flow chart are that we have tumor shrinkage and disease control. On the right-hand side leads to potentially inflammation in any part of the body. And when we treat immunotherapy side effects, we aim to treat the root cause of the inflammation using anti-inflammatory medications. Chemotherapy, on the other hand, is basically, as I mentioned earlier, something that targets rapidly dividing cells, which is what we see highlighted here on the left. It can also directly damage arteries and veins, and it can also leave your blood and enter the central nervous system and affect the nausea centers in your brainstem. And all of this leads to symptoms that can be quite severe, mild to severe. Next arrow. And basically what we do in these cases is we treat the symptoms until, the chemotherapy either is no longer needed or is no longer able to be tolerated. And so, yeah, no, thank you. And so now we're going to go ahead and talk about a few cases that we've collectively seen that highlight some of the different immune-related adverse events that we're going to talk about. So we generally think about immune-related adverse events as belonging to three different groups. One are the very common ones. Next are the serious events, immune-related adverse events. And you can see some examples written out here. And then the third are permanent events. We'll talk a little bit about these three. Slide. So, I'm gonna, here I'm talking about a patient of mine who is 65 years old and has throat cancer for which he's receiving chemotherapy and immunotherapy. And during treatment, he'd been feeling fatigue, fairly mild fatigue, but fatigue is one of the most common side effects of immunotherapy. But then after about 8 months, he started to have much more severe fatigue. So we checked what we call a cortisol level, which is a hormone in the blood made by the adrenal glands that helps us deal with stress. We always check it at 8 in the morning, and his was found to be very low. 1.2 is very low, and so that's consistent with adrenal insufficiency from immunotherapy. And so in cases like this, this is a permanent immune-related adverse event, but a very treatable one. He was started on 5 milligrams of prednisone daily, and that's the equivalent dose of what your body makes in a day. And once he was started on this, all of his symptoms returned to normal. But because it's a permanent side effect, it also becomes a permanent medication. And as long as he takes this, he should be fine. The one thing that's important to know is that should he become sick with an infection or some other sort of acute problem, he needs to tell the doctor that's taking care of him, because sometimes patients that have adrenal insufficiency end up needing extra boosts of steroid in order to cope with those transient scenarios. Next arrow. And on the bottom here, you can see on the left-hand side how common is adrenal insufficiency, or as I've written it here, low cortisol. So about 2 out of 100 people will have this symptom. And on the right here is an MRI showing, you see the red circles that are indicating the part of the brain that becomes inflamed by the immunotherapy. And when this part of the brain's inflamed, that's what leads to adrenal insufficiency in the vast majority of patients.
Okay, the next two side effects that we're going to talk about are things that are usually asymptomatic, meaning patients will really not know any change in symptoms or how they're feeling. And this includes liver inflammation, which is also known as hepatitis, or kidney inflammation, which is known as nephritis. Again, typically no symptoms to suggest that this process is going on. Before every immunotherapy infusion here in the Cancer Center, we check safety routine labs, which include liver values, things like an AST, ALT, a bilirubin. We look at kidney function, which includes your creatinine, the BUN, eGFR, which tells us overall how your kidneys are functioning. We always check these things before treatment at baseline, and then again, each time that patients come in to receive treatment. If we see mild elevations in these numbers, we often will review medication lists, because there are often medications that can affect kidney and liver function and cause those numbers to rise. So by reviewing patients' medications, we can make sure that that's not impacting these values. Sometimes if we see subtle changes in someone's kidney function, we'll try giving them some IV fluids to see if that brings the numbers down. Not all lab abnormalities are related to immunotherapy, but oftentimes we assume that all lab abnormalities are related to the treatment. So we'll try fluids. If numbers improve, we'll often repeat labs before we decide if we need to start someone on steroids. oftentimes, patients that have either, especially kidney inflammation, we can get away with lower doses or moderate doses of steroids. And I like to think of steroids such as prednisone as the brakes on the immune system. So if you see this diagram on the left, this is just a little cartoon depiction, but typically immune cells attack virus, bacteria, things that don't belong in the body. And when we cause liver or kidney inflammation, the immune cells actually start attacking the liver by mistake. So it's a friendly fire, and the prednisone is what tells those cells to stop attacking healthy tissue. The other side effect that we'll review here is joint pain, which can show up really at any time throughout treatment. Who is at high risk? We often see joint pain in patients that have either pre-existing underlying arthritis, or in folks that have an injury, an old injury that we can kind of flare up from giving immunotherapy. How do we manage symptoms? So early reporting is really one of the most important things for any immune-related side effects or toxicity. We find that the earlier we can refer patients to rheumatology to assess joints, to get a baseline, we need to evaluate, is there inflammation that we cause from immunotherapy? Is there erosion from wear and tear that we can see over time in joints? And typically the management is really conservative, meaning we'll try topicals such as Voltaren gel, lidocaine patches. We'll have patients take Tylenol or Motrin, ibuprofen if they're able to. And when patients go to see the rheumatologist, who help us to manage some of this joint pain, sometimes they'll do steroid injections. We prefer steroid injections over oral prednisone because the steroid is limited to the joint that we inject versus oral prednisone affects the whole body. So we try and limit oral steroids for this type of side effect. Sometimes we consider skipping a dose of treatment to let the joints cool off and to give the joints kind of a break from the inflammation that we've caused from treatment. Some patients end up needing a little bit of low-dose prednisone, 5 to 10 milligrams for pain that is persistent. Some patients very rarely will require opioids for pain, and other arthritis treatments that are not steroidal options are widely available, and usually rheumatology will help us to identify a treatment that we can start people on for joint pain and allow us to continue with immunotherapy treatment. So joint pain is not typically a side effect that will stop treatment. We are typically able to put patients on a treatment that is dealing with the arthritis while also allowing us to continue treating their cancer.
Okay. So now I will be focusing on more severe or persistent side effects. I will use a clinical case for the first one. This is a 59-year-old female with a past medical history of hypertension, hyperlipidemia, and GERD, who was diagnosed with a stage 3A endometrial carcinoma, which means that the tumor is localized and is not spreading anywhere. So she was treated with surgery, and then the pathological report confirmed that the tumor was localized in the endometrium. She received chemotherapy for 6 cycles in total, and when she finished, she also received radiation in the pelvis and vaginal brachytherapy. 1 year later, 1 year after she finished all the treatments, she presented to our hospital with bloody stools. So we did a CT where we found a colon mass and some peritoneal lesions. So we biopsied the colon mass, which was consistent with metastatic tumor from the previous endometrial carcinoma. So we decided to start immunotherapy, pembrolizumab, in February of that year. So she got the first dose in February and the second dose of immunotherapy in March. And then 3 weeks later, she was scheduled to receive the third dose, but she presented to clinic with cramping and bloody diarrhea with 4 to 8 bowel movements per day and also some nausea. So the main suspicion here was immune-related colitis, which is basically inflammation of the colon secondary to the immunotherapy. So we stopped the pembrolizumab and we did a scope, which showed enteritis, which is inflammation of the bowels, and colitis, so also inflammation of the colon. And we decided to start treatment with the steroids with prednisone 60 milligrams per day. Once she started the steroid treatment, she improved, but only partially because she was still having daily diarrhea while being on prednisone. So we decided to add another agent, which we call second line of immunosuppression, because these are usually stronger drugs than steroids, and we use them when the patient is not responding to steroids. So in this case, we used vedolizumab. She got the first dose and her symptoms significantly improved. And we also gave her 2 other doses. And after receiving these 3 doses of vedolizumab, while she continued to receive a prednisone taper, her symptoms completely resolved. So what we should know about colitis, about this toxicity of the inflammation of the colon. So we know that it usually happens after the second or third cycle of immunotherapy, but we also know that it can happen actually at any time, even after the first dose of immunotherapy. And we also know that patients who are treated with the combination, which is CTLA-4 treatment, one of these names is ipilimumab, together with other PD-1 treatments such as nivolumab or pembrolizumab, when we use both of them, the incidence of GI toxicity is significantly higher than when we use any of these in monotherapy. And we also know that the proportion of patients with high-grade symptoms, so more severe symptoms, is also higher when we use CTLA-4, so ipilimumab, as opposed to when we use all the other treatments alone. So what's grade 3 colitis? The guidelines define this toxicity as having more than 7 stools per day over baseline. Also, some patients can have incontinence. If the patient has an ostomy, we usually see an increased output through the ostomy, and most of these patients require admission to the hospital. Usually, the presentation is the same that this patient presented, so usually diarrhea and some nausea, but sometimes we can find what we call high-grade symptoms, which should be an alarm sign to consult and call your oncologist. These are abdominal pain, fever, blood or mucus in the stool, or sometimes if these are really severe, we can have other organs involved, and the patient can maybe present low blood pressure or tachycardia. Regarding the workup, we usually rule out other causes of diarrhea. We check viral etiologies, and also we check inflammatory parameters. So CBC, ESR, all these are usually elevated when there's inflammation of the colon. We also have these 2 markers, lactoferrin or calprotectin, that we use to monitor the curves. They are usually high at diagnosis, and then they decrease when the patient is responding. And finally, we've seen some patients developing celiac disease secondary to immunotherapy as well. We usually do imaging, the CT scan, which can show different patterns of inflammation, diffuse colitis, which is basically wall thickening all over the colon, or segmental, which is more focused on one specific portion. Patterns of involvement are very variable. The most common location is descending colon, but actually the inflammation can happen at any location throughout the GI tract. And finally, the way we have to definitely confirm the toxicity is to perform an endoscopy, also because it gives us information about the extent and severity of the inflammation. And when we see ulceration, we know that the presence of ulceration is actually related to a steroid refractory disease. And in these cases, we can even start these other stronger drugs, what we call immunosuppressants, in advance, such as infliximab or vedolizumab. And finally, it's important to know that sometimes we don't see inflammation in the scope, but when we biopsy, we actually see what we call microscopic inflammation. So we see in the tissue we biopsy that there's inflammation secondary to the immunotherapy. So the guidelines say that we should always consult the GI team, which we always do. We should halt immunotherapy in this grade 3 toxicity, meaning severe toxicity, which needs admission to the hospital or needs like long-term treatment. And we usually treat these patients with IV steroids, with a PPI, which is omeprazole, for example, to protect the gastric mucosa. And then we also put this patient on certain antibiotics. The name is Bactrim, which basically prevents patients from getting infections that are associated to long-term steroid therapy. The steroid we usually start patients on is called methylprednisolone, and the dose is usually 1 milligram per kilogram twice a day. If the patient is doing okay, then we start the taper and we decrease 10 milligrams of prednisone every week. But if they don't do that well, then we consider adding one of these stronger immunosuppressants. And once the patient's toxicity has reverted from grade 3 to grade 1, then we start the taper, again, decreasing 10 milligrams per week. Finally, we use infliximab or vedolizumab if we have refractory disease, if the patient is not responding to steroids, or if we have persistent grade 1 or more toxicity, because sometimes we can have GI colitis that actually doesn't provoke many bowel movements per day, but is very persistent and it really impacts the daily activities. And we can also repeat the scope if the patient is not having a good course, and also to rule out other causes of diarrhea, such as infections. And finally, I would like to review this second toxicity, which is inflammation of the heart, also called myocarditis, which is a very rare toxicity with a very low incidence. And actually, if we go to the guidelines and we check and look for the cardiovascular side effects, we will find adjectives such as uncommon or rare, because again, it's very, very infrequent toxicity. So the presentation can vary a lot. One of the most common symptoms is weakness or tiredness, and many patients present just with that. We can also have shortness of breath or cough. Sometimes if we do a chest X-ray, we can see all this fluid building up in the lungs because of the heart that is not working that well. And we can also see sometimes changes in the heart rhythm. Sometimes we also see patients who come because they feel dizzy or they have had a syncope, or they also have some muscular aches and pains. Regarding the diagnosis, we know that 80% of the patients, so most of them, have this inflammation of the heart in the first 3 months after starting the therapy. So this is the period of time where we should be more on alert to if we are suspecting this toxicity. And we also know that most of the patients have high troponin levels and abnormal EKG. And this is really useful because these are very cheap and accessible tools that we can pursue if we suspect inflammation of the heart. Regarding the imaging, the tricky thing about the inflammation of the heart secondary to immunotherapy is that both the heart ultrasound and the cardiac MRI, which are tests that we usually perform when we suspect inflammation of the heart from any cause, are normal in 60% of the patients. So the fact that we find this test and this imaging normal doesn't necessarily mean that the patient doesn't have this component of inflammation of the heart. And again, this is very different from inflammation of the heart from other causes, such as viral infections, for example, where we usually see this test and this imaging showing abnormal results. So sometimes we have to biopsy the heart because these imaging are normal. And then this is the test we use to confirm that the heart is inflamed due to the immune checkpoint inhibitor, to these immunotherapies. The treatment is also steroids, but the difference here is that we usually start higher doses, so 1 gram per day, which is 1,000 milligrams for 3 to 5 days. And then if the patient does okay, we transition to oral prednisone. If the patient doesn't do okay or doesn't respond to steroids, then we start immunosuppressants. And the way we have to monitor the course is the symptoms. If the patient gets better, the weakness or the muscle pain improve, or if the troponin levels go down. And it's pretty common to see sometimes a rebound of the troponin when we switch from IV methylprednisolone to oral prednisone. And in that case, what we do is we increase the dose of the steroids and we add other immunosuppressants. Cellcept is one of the most commonly used for heart. And finally, it's also important to know that muscular inflammation and heart inflammation can happen at the same time. This is also a rare toxicity, but more than half of the patients have both of them. When each of them presents, it's usually overlapping with the other one. So when we see this, both muscle and heart inflammation, they usually do not respond that well to steroids. And that's why we always do workup for both toxicities, just to check that none of them, both of them, or one of them are present, and we start treatment really early. And just a final conclusion, just to highlight that fatigue is a very common symptom that we see in cancer patients in general, and also in patients treated with immunotherapy. And it can be the manifestation of heart inflammation, of muscle inflammation, of brain inflammation, of liver disease, of thyroid disease, or adrenal insufficiency, as we saw in the previous case. And it's, again, very uncommon to be severe, but it's very important to have all the differential of the different diagnoses on the differential. And it's very, very important for the patients to report any symptoms so that we are sure to rule out any toxicity.
Okay, so that was an overview of all of the different types of toxicities that we can see after immunotherapy. With immunotherapy, unlike with chemotherapy, it's a lot harder to predict who might get toxicities, which is why we highlighted a little bit of all of the different ranges, from some of the more common toxicities, like the endocrine toxicities that are just treated with hormone replacement, or arthritis that can be treated with low doses of steroids or local joint therapies, to some of the really rare toxicities, like myocarditis is one of the most rare toxicities that we see. As Dr. Merkin highlighted in the beginning, immunotherapy works differently from chemotherapy, and in many patients, immunotherapy is tolerated much better than traditional chemotherapy would be. The side effects that we see with immunotherapy are from an overactivation of the immune system, leading to those different types of inflammation that you just heard about. One of the very positive things with this, it's hard to talk about anything positive with side effects, but we've seen in multiple different sets of data that immunotherapy side effects, or this overactivation of the immune system, is actually associated with better tumor outcomes. The thought is that if the immune system is getting overactivated and causing these side effects, it's also overactivated when it's attacking the cancer cells. So the graph on the left, you can see that patients who develop the immunotherapy toxicity in red actually had a better progression-free survival, or their cancer responded for longer than the patients who did not get those immunotherapy side effects. And the graph in the right actually shows that this is also extended to a survival benefit, where patients who did develop the immunotherapy toxicity actually lived longer than the patients who didn't get immunotherapy toxicities. So this overactivation of the immune system does seem to correlate with an increased response against the tumor as well. One of the really common questions that we get is, can immunotherapy be restarted if I've had some of these immunotherapy side effects or immune-related adverse events? And the answer to that is really an individualized discussion based on the risk-benefit ratio for each patient. And the things that we think about in the left here, kind of factors that affect the risk of restarting immunotherapy, are things like, what types of immunotherapy side effect was it? How severe was it? How easy was it to control with steroids, or did they require some extra immunosuppressive agents? And then one factor that I'll talk about in a minute is sometimes we can give prophylactic medicines ahead of time to help reduce the risk that the immunotherapy side effect will come back. And that's something we use a lot with colitis, for example. When we're thinking about the benefits of immunotherapy, we look at kind of the whole overall picture and think about what other cancer treatment options are available for their particular type of cancer. So if there are other really good anti-cancer treatment options, your oncologist might recommend, let's try something else right now, and we could always come back to immunotherapy later. Or if they think immunotherapy is the best thing for your cancer, they may talk about resuming immunotherapy depending on the risks. So in general, we can often restart immunotherapy after some of the lower severity immunotherapy related adverse events. And this includes many times if patients have inflammation of the skin or rashes or endocrine side effects or rheumatological side effects, we're often able to continue immunotherapy in those cases. Another common question is, what is the risk that the side effect will reoccur after immunotherapy is restarted? So if we look at 10 people who had an immunotherapy side effect and we retreat them with immunotherapy again, half of them, or 5 out of the 10, will not have any further IRAEs. About 30% will have a recurrence of the same IRAE that they had in the first place. And somewhere between 20 and 30% will have a new IRAE develop. So if they had colitis for their first IRAE, maybe they have arthritis after they're retreated with immunotherapy. In some cases, we're able to switch from giving patients 2 different immunotherapy medicines. A common example would be ipilimumab plus nivolumab, to only giving 1 immunotherapy medicine like nivolumab alone in order to reduce the chance that the immunotherapy side effect will come back. And then we also look if there are different ways that we can try to reduce the risk of the immunotherapy side effects coming back. And in many cases, we try to add prophylactic medicines at the time that we're restarting the immunotherapy in order to reduce the chance that that immunotherapy side effect will come back. And this is used in colitis, for example. So what happens with colitis is the T cells, or these blue immune cells in the blood vessel, come out into the gut and cause damage of the healthy gut cells. So we have 2 different medicines that can try to help reduce the chance that the immune cells will cause damage of the healthy gut cells. So Vital is a medicine we use sometimes that stops the T cells from leaving the blood vessel and going into the gut and can help reduce the inflammation or the risk of colitis coming back. Or infliximab is another medicine that helps stop the T cells from becoming activated to cause the gut damage. So in many cases, we've been able to successfully start patients on one of these 2 medicines when we're resuming their immunotherapy to prevent the colitis from recurring. And these are also 2 of the medicines that we can use to treat the colitis for patients who are having refractory symptoms or not responding as well to steroids. Another question that we get commonly is if immunotherapy side effects are an overactivation of the immune system, what if I already have an autoimmune disease that is an overactivation of my immune system? And we do have some good data from the experience of treating patients with pre-existing autoimmune diseases to help us figure out what might happen. You know, a lot of clinical trials did not include patients who had active autoimmune diseases. So this is based on more of the clinical experience of what we've seen with patients with autoimmune diseases who have been treated with immunotherapy. And in general, we've seen about 25 to 40% of patients with pre-existing autoimmune diseases might have an exacerbation on immunotherapy. So rheumatological disorders such as like rheumatoid arthritis are some of the ones that we most commonly see flare. We're often able to continue treating patients with immunotherapy despite the autoimmune disease flare. So up to 75% of patients can continue on with immunotherapy despite a potential flare of their autoimmune disease. We do know that patients who have a really active autoimmune disease before the immunotherapy starts are the most likely to experience a flare. So we'll work really closely with their rheumatologist or gastroenterologist or the doctor who's treating their autoimmune disease to help make sure their autoimmune disease is under as good control as possible before starting immunotherapy. We also know about 30% of patients will develop a different immune-related adverse event unrelated to their prior autoimmune disease. But both the autoimmune disease flares and the immune-related adverse events respond well to the regular treatment approaches for these types of disease. So really, when we're thinking about whether to treat patients with an autoimmune disease with immunotherapy, it's also a risk-benefit discussion between the oncologist and the patient, and it'll depend on things like what autoimmune disease is it, how easily could a potential flare of that autoimmune disease be treated, and what are the other treatment options available to the patient.
Okay. So, survivorship is, there's a lot of different classifications of survivorship. We'll be talking about time from stopping treatment all the way through follow-up. So, the good news is that cancer rates are declining and also that patients are living longer. So, that's a great thing. The living longer part also means that we have to come up with better and new ways to manage any sort of lingering side effects that can come from the cancer and from the treatments. In 2020, over 230,000 people were treated with immunotherapy in the US, so that's a lot of potential patients to have in survivorship, especially if more patients are living longer. Like I said, trying to make sure that we're addressing all those needs. I know that earlier we talked about three kind of different buckets of side effects and how there's very few that are left behind, but we're learning the longer that we're doing this, that there probably are more things lingering than we previously thought. Next slide, unless I'm directing. So, like I said before, I run our immunotherapy survivorship program in the melanoma clinic. And while not every single program has this specific clinic, the bulk of services that we refer patients to and the care coordination that we do are available to everyone in the cancer center. So while this survivorship program you may not be eligible for it, all of the things that I'm going to talk about in terms of referrals and resources are things that most patients are eligible for. So the goal of our survivorship program is to really make sure that we're helping patients transition back into their kind of quote unquote regular life, making sure that they're connected with their primary care providers, they're getting adequate screening. There's lots of different things, which Alex will talk about in a minute, but that come up as problems because of side effects from treatment and how we manage those things. Steroids can affect bone health. Endocrinopathies can affect bone health, can affect energy. So lots of things to make sure we're addressing. This is an example of a survey that we send to patients. They fill this out before their visit, and it really just helps frame, what's going on with them still from a symptom standpoint, but also, at the bottom, make sure that we're addressing what's most important to them. Our goals for the visit might not be the same as what a patient's goal is, and we want to make sure that we're centering the visit around what patients want. This is an example of a care plan. And so, like I said, this is kind of specific for our clinic, but it's just a formal summary about everything that's happened during their treatment, side effects, and any sort of, specialist that they have. We've heard feedback from primary care providers and specialists that this has been really helpful so that they, know who's doing what in the follow-up realm. When patients are on active treatment, basically the oncology team is doing everything. And so I think once we get into the survivorship mode, it is helpful to reframe for patients and providers that the care is a little bit more spread out again.
So we've talked a lot about steroids typically being the way that we manage immune-related side effects, and some steroid toxicity, meaning steroid side effect that we can see, especially in the survivorship phase of someone's care. We spoke about adrenal insufficiency, but with long-term chronic steroid use, we worry about secondary infections, steroid myopathy or weakness, skin changes. Steroids can also cause levels of insomnia when patients are on higher doses, eye changes such as glaucoma, impaired wound healing, weight gain, mood changes, changes in blood pressure, and also osteoporosis. And that is something that we'll discuss about kind of how do we monitor, how do we manage, how do we make sure that the team is appropriately monitoring for these potential toxicities. Next slide. So one way that we measure it is called a FRAC score, which is a prediction of a patient's 10-year risk of fracture, so of breaking a hip or other major bone. On the right here, you'll see an example of a questionnaire. It's an assessment tool that we use prior to our survivorship visits to calculate a patient's bone mineral density and other risk factors to calculate their overall score. Things that we take into consideration when calculating a score include someone's age, sex, weight, height, any history of fractures, family history, do they have rheumatoid arthritis history, smoking, alcohol consumption, and most importantly, which is included on everyone's care plan that gets sent to PCPs and other specialists, is lifetime steroid medication use. So we calculate that number, and that goes back to whether patients had a long steroid taper for something like colitis, or if they're also currently on 5 milligrams low dose prednisone for adrenal insufficiency. We take all that into account to calculate a total lifetime steroid dose. And essentially a 10% or higher 10-year fracture risk is the threshold that we use that could indicate a need for something called a DEXA scan. And then we provide that recommendation to patients' PCPs in the care plan. And that gets ordered and monitored to make sure that we're not missing that piece of follow-up care.
So in our survivorship program, this is on the first several patients that went through our clinic, just kind of highlighting what types of referrals we're seeing. The most common referral is to nutrition. This was kind of before a lot of the mind-body referral came through, or that program really launched. So, that's, I think, taken first place. But most patients, if you just can advance, yeah, most patients did require at least one referral. So 2/3 of patients had at least one referral, and you can see some of the patients had 5, 6, or even 7 different referrals to different programs. So depending on what patients' needs are, we have lots of services to connect them to. Another question we get asked a lot about in survivorship has to do with pregnancy and fertility. And there's lots of different things to consider here. And so these are just kind of the most common things that we review during that time. We are often, weighing the risks and benefits in terms of the risk for the person carrying the baby, the risk to the baby, what that means for their, cancer recurrence, the safety, all of those types of things. And so there, are a lot of different studies out there now that are nice to be able to actually review. I think in years past has been a big question mark, but I'd say in the last several years, we actually have some real data that overall looks like things are pretty safe. Actually, I think a lot safer than we had initially thought that they would be. So, one of the biggest questions is, will getting pregnant increase the risk of cancer recurrence? Pregnancy can kind of weaken the immune system a little bit during that time, for lack of a better, term. And so that's always been a concern, specifically in the melanoma world, but definitely thinking about how that might interact with immunotherapy or people after they've received immunotherapy. So the good news is this study showed that getting pregnant after immunotherapy did not increase the risk of a recurrence. Um, this is looking at the effects of immunotherapy, sometimes during, which were accidental, or after treatment. And so we usually want patients to wait at least 6 months before getting pregnant. We really want to make sure all of the drug itself is out of the system, and until we're out of the highest risk time for side effects to be, occurring. And so there are several reports, as you can see in that top graph, of people who got pregnant while on immunotherapy and, gave birth to healthy children, and some who were monitored even through several years after birth, and we're doing well. There have been no reports of fetal malformation. So unlike certain chemotherapies, which can, cause harm, we haven't seen that with immunotherapy, which is good. But there are a few reports of the baby actually developing immune-related side effects. So I'm sure this is, something that if somebody got pregnant shortly after, during immunotherapy, we would want to be on the lookout for. One of the biggest things that has not been looked into is really fertility itself. Like, can people get pregnant? Again, no surprise that this has not been well studied, but it's definitely an area that is being looked at more thoroughly now. Um, I think if even probably 5 years ago, but definitely, when immunotherapy first came out, many providers felt like this probably didn't affect fertility. But as you can see from this like summary, looking at a bunch of different studies, and actually there are several patients who do have changes in their fertility, both, men and women. Um, so, on one of the prior slides, there was a link to our fertility clinics, but these are many of the other resources that we have as well. Like I said, a lot of patients get referred to the Mind Body program for survivors. This is a really great tool to help integrate people back into um, their kind of regular day. It goes over nutrition and anxiety, especially around scans. It's a really, really great program. There's also a peer mentoring program that we refer people to. If you feel like you'd be a great resource to others, you can apply to be a mentor, or if you'd really like to talk to somebody who's been through this before, you can be a peer. If you're really focused just on kind of physical health as opposed to like physical and mental, health improvement, the lifestyle medicine program is a great resource. And they also have a lot of online series that you can watch like whenever you want, link below to the webinar. Many patients become like very physically deconditioned during their cancer treatment, sometimes from the immunotherapy, sometimes surgery, radiation. And so the cancer rehabilitation program is really like a good stepping, point. Even sometimes before patients could, get to physical therapy, the rehab, program can help figure out what does a patient need. And then the integrative therapies programs, acupuncture, massage, these are all things patients can get even while they're on treatment, up in infusion, and at some of our satellites. So, really great programs to get. And then sleep. Sleep is always a problem. It's a problem for people on treatment, off treatment. And so there are specific programs for that too. So like I said, all patients are eligible for these. It's not, melanoma specific or immunotherapy specific. So definitely things that you can talk with your providers about. The two cancer specific programs outside of melanoma are for the BMT program and then paving program for breast cancer survivors. There's a lot of other external resources too. So First Ascent is like a camp that patients can, go to and meet other cancer patients from all over the country, which is great. And then there's a lot of like external cancer specific support groups. So those are, the best way to figure out if those exist is to ask your individual providers. So MGH does continue to grow its survivorship population and resources. So like I said in the beginning, even if, you don't have a cancer-specific survivorship program, all of these are resources that we refer people to or shepherd people to are available to all patients. So definitely make sure you check with your provider if any of those sound interesting to you, and, to check out the survivorship page yourself and see if, there's anything we didn't talk about, because there's a lot of resources that we didn't even get to.
All right, so I see we have just a couple of minutes left, so maybe I'll just try to address a couple of the questions that came in through the chat. I think there were a few questions about resuming immunotherapy after colitis or other immune-related side effects are occur and are treated. And that's where it really becomes an individual discussion between the patient and their doctor. In many cases, we are able to retreat with immunotherapy with some of those other medications like infliximab or vedolizumab. In some cases, the discussion is that it might be better to do an alternative treatment approach or not retreat with immunotherapy. We don't really have any good data on which patients are most likely to develop some of these side effects from immunotherapy, other than if they already have an autoimmune disease affecting that particular type of side effect, they may be more likely to develop a side effect. So if somebody has inflammatory bowel disease before they start immunotherapy, they might be more likely to develop immunotherapy-associated colitis, for example. There was a question about the side effects from vedolizumab or infliximab. I'll say both of those are generally pretty well tolerated. The biggest side effect that we think about is infliximab in particular is a type of immunosuppression. So the infliximab and steroids both can cause patients to be more immunosuppressed and maybe more likely to develop other types of infection. And then there's also a question about if the cancer returns, will immunotherapy be less effective than the first time? And I think this is actually an area where we actually do have some really great data that immunotherapy can still be really effective if the cancer comes back, which is why a lot of times the strategy we use is if somebody develops one of these side effects, we'll pause immunotherapy for a while and then can resume it if the cancer comes back. And we see really good responses in that setting as well. So I don't know if any of the other panelists also wanted to comment on anything else in the questions in the chat. I know we're almost at the hour.
There's a question in here asking about in a scenario where surgery, chemo, radiation, and immunotherapy are not applicable or have kind of been already tried and are no longer working, what kind of options are available? Sometimes a clinical trial is available in that scenario. But really it's a question that's very hard to answer across all cancers because it's usually it's an answer that's very specific to the kind of cancer that you have. Each cancer is treated differently, with immunotherapy being a key component of treatment for many kinds of cancers. But figuring out the exact perfect combination of these various treatments for each patient and in what order is very dependent on what kind of cancer you have.
Yeah, and maybe just regarding the side effects from infliximab or these immunosuppressants, just to clarify that we usually check because sometimes patients can have had like viral hepatitis or tuberculosis in the past and they are latent, but we always check these like serologies just to make sure that the immunosuppressant will not reactivate these, like, let's say, mild underlying infections.
Thank you all. This was extremely helpful. Before we end today's session, you have provided many great supportive resources, online resources. Do you have any recommended websites one can go to learn more about immunotherapy?
Yeah, I think, there are a lot of resources in the melanoma world just because we've been giving immunotherapy for the longest, amount of time. So, we can certainly provide like links, to those types of things where patients can go on and look. There's a non-profit called AIM, AIM, that has a great resource for basically every immunotherapy type. There's like a patient packet that goes through each, organ system and has information about side effects that's easy to like kind of understand. So I think that's a great resource.
Wonderful.
And I would add that if you ask, we have pre-written handouts about the various medications that we offer people. So if you ask your doctor for printouts on these medications, it's usually very easy to get them.
Thank you, Dr. Merkin. We are at time. Special thank you to the immunotherapy team. This was extremely helpful. And for everyone joining today, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Take care.